as we continue our Nova Southeastern University Critical Care Symposium highlights. Very lucky to invite special guest Patricia Louzon on, talking about her discussion into the PADIS guidelines promoting calm amongst chaos, updating PADIS for a changing ICU. Patricia is a critical care and emergency medicine clinical pharmacy manager. Welcome. How are you doing today?
Thanks for having me. I'm so excited about this Nova Symposium and would love to hear more about it or have everyone else hear more about it.
Yeah, it's really exciting. Like the great talks, like you are one of a number of awesome critical care pharmacists and multidisciplinary speakers, and really excited to get into your discussion a little bit. Going into the focused update of the 2025 PADIS guidelines. So give the audience a little bit of kind of a preview behind the curtain. What's your talk what can we expect your talk to cover and kind of go over?
Yes, so I mean, the obvious part is I'll focus on there's 5 PICO questions in the focused update, which is a little bit unique in itself. I think guidelines are moving a little bit more towards that focused update. So, partially because of that, and partially because one of the biggest takeaways I had on being on the guidelines committee is really the methods and everything that goes into the guideline development. So, I'm actually going to focus a little bit in my talk too and diving into why each recommendation was made, what are all of the steps in guideline development, how are PICO questions chosen, what's the process in looking at the evidence, how do you decide to make a recommendation or not make a recommendation, and then really you as an audience, by understanding the methods a little bit better, can oftentimes use that to apply what sometimes may seem like a low level of evidence to make a recommendation. You can kind of, by understanding the methods and how we look at the data, use that to kind of apply that a little bit better to your practice. So I'm going to dive a little bit into that as well. And I'm also really interested in hearing audience thoughts when I get there and just kind of how people are applying it to their practice and how they're interpreting some of the recommendations or lack of recommendations in our case.
So what you have sort of highlighted is the I'm not going to give it away, but there's a very funny meme talking about the amount of evidence into the recommendations. So how should we as critical care pharmacists interpret some of these recommendations, knowing the fact that, right, a lot of them are based on very little to no evidence?
Yes. So I think there's 2 elements there. One is I would imagine there's a lot of people out there who love research and are looking for areas of research. So one is looking at if recommendations don't have a lot of evidence to base their recommendation on, well, that's a future area of research. So that's number one, is realizing what were the limitations in data and maybe how could I as a researcher step in and build some of that evidence base. So that's one thing I think. And then the second thing is understanding the methods of the guidelines, as I mentioned earlier, and really diving into where the recommendation came from and each of the guideline studies that were included. So, for example, melatonin subgroup is what I was on, and that's kind of a great example because the recommendation in the guidelines is to use melatonin. But when you look at the actual evidence and break down all of the outcomes that we looked at, you can kind of see what's driving that. And it was actually a delirium reduction. It wasn't necessarily a patient improvement in sleep. So when you start to dive into that, you say, okay, well, a lot of times you look at the risk benefit as well. The adverse events are very low. The data shows that. And it's possible that we reduce delirium. Whether or not we actually are improving patient sleep is still a question that's out there, I think, and that's a big area of future research. But you can look at the evidence and say, okay, this is where the recommendation is coming from. And if I could potentially reduce delirium with little to no adverse effects and maybe impact patient sleep, then that's where that recommendation is coming from. So I think learning to look deeper into each recommendation and the actual outcomes that are looked at and what's driving it, I think is a big driver of that and how you can apply it to your practice.
We buried the lead a little bit here, right? Because if you go and either in person or virtually register, which everyone should do, right? The second annual symposium, Saturday, February 21st, and the lead that we buried. Right, we're talking to one of the co-guideline authors, right, pharmacist author on the RSI or the 2025 PADIS guidelines, right? We just did the RSI trial, my mind. But yeah, and highlighting in the sort of melatonin subgroup, that's one of the changes that I've made getting educated that going straight to the max melatonin dose may not be the best way in terms of like from some of the evidence of how we dose it. So I like that we're kind of getting some team melatonin activity going on over here.
That's right. That's right.
So when you're involved in something like this, what is I think a lot of us have different sort of anecdotal practice styles, and you probably get a lot of that when you're on a guideline and getting to see all the different practice styles and things. Has there been a change or a difference in preference or things in your style after being involved and learning in something like this?
Yeah, I think definitely there's some things that might sway you one way or the other. Mobility. Mobility is a huge one. I think the interesting thing about this guidelines is they call it enhanced mobility. And what does that mean? So I think first understanding the recommendation is what is enhanced mobility? And we defined it really as anything above your standard mobility. So whatever your unit is doing. Probably the easiest application of that might be twice daily mobility instead of once daily probably is the most understandable and maybe applicable to each unit. And so I think that's a huge one that I have really focused on a lot is not just do we get the patient up once, but a daily reassessment on every shift and really making it everybody's role. There are things like mobility teams, making sure it's a nursing role and not just physical therapy and really making sure everyone's working together and it's everybody's role to be talking about mobility, I think is a huge one that you can take away from these guidelines too. And that enhanced mobility piece had a ton of evidence. By far, they had an insane amount of trials showing that there is benefit to this and that I really, really upped my efforts in advocating for that for every patient.
So you highlighted it that one of the things you're looking forward to, and myself as well, is the discussion about a lot of everyone else's sort of practices and their, PADIS preferences and things. So is there you have a few different discussion questions. Is there one that you're most excited to hear the audience talk about, or did you think there might be the most amount of kind of differences or discussion with?
I would love to hear how people are applying the mobility. What are they defining mobility as at their institutions, and how have they maybe made efforts to make it enhanced? Definitely melatonin. Are you using a melatonin in everyone, or have you just maybe altered your dose, even though the guidelines don't specifically talk about recommending a dose or duration? So being on the melatonin subgroup, of course, I'm most kind of interested in people's thoughts on that recommendation is maybe that would have been a little surprising to some people, perhaps. And then also the antipsychotic recommendation, I think kind of figuring out how people are applying that. I think there's still a lot of remaining questions there, especially between hyperactive delirium and hypoactive delirium that the guidelines didn't really answer. So I think we still have a lot of variability in practice there that I'm interested in seeing what people are doing there. I think the other piece too is transitions of care, which is a huge kind of area of pharmacy. I think that's growing and growing. And maybe how are you applying some of these guideline recommendations to improving your transitions of care?
Man, is it Saturday the 21st yet? I just hearing this got me so excited. So again, the second annual Nova Southeastern University Critical Care Symposium, Patricia Louzon promoting calm amongst chaos, updating the PADIS for a changing ICU. This is going to be a great session, one of many through the day, in person, virtual, right? It's in the fun and sun, right? We're chiseling our cars out here in the Midwest, so very excited to get some sun in my life. But Patricia, thanks not only for what's going to be an awesome talk, all you've done with PADIS, and coming on and doing a little bit of a highlight. We greatly appreciate it.
Of course, thanks for having me. And I'm looking forward to seeing everyone at the symposium in February.